My name is Dr. Mark Silverberg. I'm a gastroenterologist at Mount Sinai Hospital in the University of Toronto. I've been taking care of IBD patients for more than 10 years, and I see several hundred IBD patients every month. I work at the Zane Cohen Center for Digestive Diseases with a very talented group of individuals who all take care of IBD patients. Unfortunately, in Canada, IBD is a very common disease, and we don't understand exactly why. It typically has been something that presents in European ancestry Caucasian populations, but it does seem to be emerging in minority populations, for example, in the Asian population in Toronto. Inflammatory bowel disease has two major types, ulcerative colitis and Crohn's disease. Both of these are inflammatory conditions of the digestive tract that cause a variety of symptoms. Ulcerative colitis typically presents with rectal bleeding, diarrhea, abdominal pain, and cramping. Crohn's disease, on the other hand, can affect any part of the digestive tract and can result in other symptoms such as weight loss, abdominal pain, and bowel obstructions. The inflammatory bowel diseases don't have a known cause as yet. We believe that they're caused in someone who has a genetic predisposition that is then exposed to an environmental factor that may cause the disease to present. For example, we believe that the bacterial composition in the intestinal tract may be a significant environmental factor that leads to inflammatory bowel disease. We need to do a number of tests to make a definite diagnosis of ulcerative colitis. We start with blood tests and stool cultures to make sure there isn't an infection present, which can mimic the presentation of ulcerative colitis. We also would eventually do an endoscopy or a sigmoidoscopy, or it's also known as a colonoscopy. With that test, we pass a tube with a camera into the colon so we can directly visualize the pattern of inflammation. We can also take biopsy samples, and that appearance of the endoscopy as well as the biopsy results are what will give us the diagnosis of ulcerative colitis. Ulcerative colitis can be classified in several ways. One is by disease extent and another is by disease severity. There are categories that are called mild, moderate, and severe disease. So mild ulcerative colitis is typically characterized by fewer than 4 bowel motions per day, and only several may be accompanied by blood, and there may not be systemic features such as weight loss or abdominal pain. However, there's also the severe end of the spectrum. So severe ulcerative colitis is typically characterized by many bowel motions per day, over 6 to 8, and all of them accompanied by bleeding. And there may also be elevations in certain blood tests that the physician would order, such as the C-reactive protein. And then there's the moderate category, which is just in between mild and severe. The disease extent in ulcerative colitis is typically broken down into 3 categories. There's something called ulcerative proctitis, which is where the inflammatory process really affects only the rectum. There's left-sided ulcerative colitis, where the inflammation extends continuously from the rectum to about the splenic flexure. And then there's extensive ulcerative colitis, or sometimes pancolitis, where the inflammation extends beyond the splenic flexure and sometimes all the way around to the cecum. Once we make a diagnosis of ulcerative colitis, we then need to devise a management strategy. Our goals of treatment in ulcerative colitis are to get patients to feel better as quickly as possible. So we want their bowel motions to be normalized, to get down to a normal frequency and caliber of stool. We want the rectal bleeding to disappear completely, and we want any blood test parameters to resolve toward a normal state. Ideally, we would also like the endoscopy appearance to normalize towards no inflammation that would be visualized. To achieve these goals, we have to pick a treatment that will allow us to accomplish that. Treatments that we use are typically chosen based on the presentation of the patient. So, for example, if a patient has a milder type of colitis that isn't as extensive, we might pick one type of therapy, whereas a patient that has extensive ulcerative colitis and a more severe presentation would have another form of therapy chosen. With a patient that presents with mild to moderate disease, the typical first-line therapy for ulcerative colitis are the 5-ASA class of drugs, also known as mesalamine. These drugs are topically acting agents that can be taken both orally as well as by enema or suppositories that act to heal the lining of the bowel and stop the inflammatory process. All medications have side effects, but we're quite fortunate that 5-ASA class of therapy has very few side effects and generally are very safe medications. However, there are certain things that you should think about when taking 5-ASA medication. A physician should be monitoring kidney function at least once a year to keep an eye on any issues that may arise there, and extremely rarely there can be complications that affect the pancreas, the liver, or the lungs. So we do recommend that once a year, even patients who are doing extremely well see their physician to review these issues and to tell their doctor if they do have any unusual symptoms while on 5-ASA therapy. 5-ASA products are very good products to treat mild to moderate ulcerative colitis. There are quite a number of them on the market in Canada at the moment, for example, Pentasa, Salifalk, Azokal, and several others. The main differences between these medications are the way the medication is released into the intestinal tract. Some of them, such as Azokal or Salifalk, are pH dependent and are really looking at the pH of the gut to determine where the active medication is released in the intestinal tract. However, Pentasa, as an example, is a time-dependent release, so the drug releases independent of the pH in the intestinal tract. The goal of 5-ASA medication release is to get as much of the active product to the area of inflammation as possible. We typically prescribe oral 5-ASA initially at a dose of 4 grams per day. Ideally, you want to use medications that have more of the medicine in a single tablet to reduce the pill burden for patients. So ideally, for example, Pentasa would be prescribed as 1 gram tablet and we would give 4 grams per day. In addition, giving rectal therapy as an enema or suppository is a very useful approach, and studies have shown that combination of oral as well as topical treatments work better to get patients into remission more quickly. Typically, we recommend treatment for at least 4 weeks with enema therapy to get the maximal benefit and healing of the bowel. However, we recognize that it is difficult for our patients to maintain those types of treatments for a long period of time. However, I find it important to emphasize the role of combination therapy to patients because it really is a very effective way of getting as much drug as possible to the area that's often most inflamed, which is in the rectum. So I find spending a little extra time with the patient to explain the importance of an enema is what gets them to use it more, and they'll find that the benefit helps encourage them to continue using it. We often tailor the approach of therapy to the disease extent. So for example, when the inflammation really is limited to the rectum or ulcerative proctitis, often one only needs topical therapy to treat it. So for example, I might prescribe only an enema or a suppository to really target the affected area primarily. Left-sided disease, again, one may use only enema therapy to get the inflamed area that's most affected. However, often, again, oral as well as combination therapy with enemas may be a more effective strategy. And then with extensive or pancolitis, it's most often effective to use oral therapy primarily, but still adding combination therapy with an enema may be helpful to relieve the urgency that many patients have. After the patient has responded to the initial treatment, then we get into what's called maintenance therapy. Unfortunately, ulcerative colitis is a chronic disease and often is characterized by many relapses ongoing in the future. And we do encourage patients to stay on maintenance medical therapy for as long as possible in order to reduce the risk of recurrent flares. So for example, we would encourage patients to stay on oral 5-ASA medications indefinitely, and sometimes the dose can be reduced to 2 to 3 grams per day in order to effectively maintain remission. Typically, after we initiate treatment, I would see the patient again within 4 to 8 weeks after starting therapy and assess how they're doing. We do that through a number of approaches. Primarily, we ask about symptoms. Have the bowel motions decreased? Has the bleeding resolved? Are the people feeling better generally? And in addition to that, we may even have a look with a sigmoidoscopy or repeat some of the blood tests to look for improvement in those that were abnormal to begin with. Certainly, people are very sensitive about this part of their body. They have a lot of symptoms that are embarrassing to them, and they can be quite nervous discussing this aspect of their health. I do encourage patients to stay on medical therapy in the long term, and that's really to give them some predictability in their life. Otherwise, the disease can flare at inopportune times for the patient, and then they're stuck with dealing with what could be a more serious flare. So staying on regular medication is advisable. What I tell people is that imagine that they had the flare that they just had and that this comes up right before exams or before they have an important work event. So I think that encourages them to stay on medical therapy, and we do have good evidence that staying on regular medical therapy keeps people in remission in the long term. Additionally, we see that with uncontrolled inflammation, even at low levels, there can be chronic damage done to the colon. There can also be an increased risk of colon cancer with uncontrolled inflammation. And for those reasons, it is important to stay on regular maintenance therapy with 5-ASA medication. The vast majority of patients do very well on 5-ASA medical therapy for ulcerative colitis. However, a small proportion of patients will develop a more severe form of ulcerative colitis that is not responsive to 5-ASA therapy. In that case, we do have to progress on to other therapies that are effective for that form of severe disease, but also carry with them some more side effects. Agents like steroids, biologic therapies, and immune suppressants are used frequently and with some success for severe ulcerative colitis. There are a number of naturopathic approaches that people often try for their ulcerative colitis, and generally I don't have a problem with people doing this, although one must realize there's very little scientific evidence that these benefit the patient. An area of promise that I do think may be helpful is to alter the gut bacterial composition of the colon or changing the microbiome. This can be accomplished by several different approaches. One way is to take probiotics orally. Probiotics are available in many different formulations, and it is important to take a probiotic that does have live bacteria. For example, VSL number 3 has good quality control and some scientific evidence that it may be effective in the treatment of IBD. Many patients ask about what they should eat and how they should manage their diet when they have ulcerative colitis. I do believe that the diet is a very important component of ulcerative colitis, both maintaining remission and in flares. However, unfortunately, we really don't have very specific evidence for certain food groups to lead to better outcomes. What I typically tell patients is to individualize it for their own situation and look at the foods that they find exacerbate their bowel symptoms and try to avoid those. I would say there are not general rules that I can give to all patients that would effectively treat their colitis, but we do think that ultimately we will one day find evidence that certain food components do positively or negatively affect the outcomes in the treatment of ulcerative colitis. Although ulcerative colitis is a chronic disease with no known cause presently, I think people could be encouraged that there's a lot of excellent research being done and a lot of progress being made. For example, we've identified many of the genetic factors that are leading to ulcerative colitis, and we're starting to really make headway in understanding the environmental side of it. For example, what types of bacterial compositions can lead to the disease occurring. So I think the future is bright in terms of one day understanding the causes and potentially preventing the disease from occurring. In the meantime, while we're working hard on this, there are therapies such as the 5-ASA class of drugs that can effectively control the symptoms and give patients a good quality of life for the foreseeable future.